It's exactly 12 o'clock, so I'm going to go with the afternoon. I'm going to ask you please to forgive my voice. I woke up with a frog this morning. He wasn't my husband, but what can we do? Okay. My name is Lee Saltz, and I'm the Vice President of Advocacy for the National Council of Jewish Women, Los Angeles. And I would like to welcome you to Council House today to hear our illustrious, and I do have to put quotation marks on that panel, speak about the future of health in California. For those of you who have not been here before, please bear with me who have been here before, please bear with me while I just do a little spiel for the people who have not been here before. The National Council of Jewish Women is a grassroots organization of volunteers and advocates, and we are inspired by Jewish values. We strive for social justice by improving the quality of life for women, children, and families.
Your mic is on.
Went off again. Try some.
Press the bottom, Lee. The bottom.
Yeah.
Now, sir, okay. Women, children, and families. And of course, what could be more important to women, children, families, and to all of us but health care? So, the fact that you're all here means that you are interested in knowing what is going on and what will be going on. This organization is is over 100 years old, and for lo these many years we have worked.
Sorry about that. Technical issues.
Use one from the
Yeah, we're getting another one right now.
Use this?
No, she'll get another wireless. We have other wireless.
Okay, yeah, I'll do it.
It's tied down. So
Is it tied in?
we do it right in front.
Okay.
There you go.
Okay, so we said that this organization is over 100 years old, and that for all these years we have worked for the advancement and well-being and the status of women, for the advancement and well-being of children and families, and we certainly work for the insurance and advancing of individual rights, and we work for the enhancement and quality of Jewish rights. Basically, our mission is the well-being and status of women, children, and families. Now, before I go on, because there's so many new faces here, and it's just so wonderful to see new faces, I would just love to invite you to think about, if you like what you see here, and you like what we hear here, we're always looking for new members. You do not have to be Jewish, you do not have to be a woman. All you have to care about is making a difference in the world and becoming an advocate for social justice. There are a lot of people here who can talk to you and explain to you how this organization works. Now, on your chair are many, many pieces of paper. So I just want to go through them with you very quickly. The first thing you will see is a list of papers with the bios on all these people. These people are illustrious people who have worked in many, many fields and bring wealth of knowledge. So please take some time to read their bios. You also have on your chair a little 3x5 card, which is for questions. You can write them down. We will pick them up at 1 o'clock when the presentation is over. Also, you will find a yellow card, which is for you to evaluate today's program. We do take your opinions seriously, And when we go to plan another program, we say, hey, you know, what did they say? What is it they want? What did they like? What didn't they like? So please fill those out and leave them on the tables before you leave. And I'd like to give a special thanks to our director, Ruth Williams, because without her, we never would have been able to put these things together. And Hillary, could you come in? Okay, and this is our director, Hillary Selvin. She's our executive director. And Hillary is out there, and she will be able to answer questions for you. She's the person that makes all this work. So we're very happy to have her here with us today. You will also find on your chairs, some other papers. Because what's happened is we have now become a central point for a lot of wonderful events. And so please take a moment to look at our new events. We have a women's training project to train women and men to be effective advocates. That's going to start on April 7th. We have a workshop for parents on teenage violence. And if any of you have teenagers, it is critical that you talk to them about dating and what is acceptable and what is not acceptable in terms of dating and the violence that sometimes comes into the mixture of dating and adolescence. Then we have been very fortunate to be able to get wonderful films. So on April 11th, in the evening at 6:30, we will be showing the film The Carbon Nation. The Carbon Nation is about our carbon footprint here in America and how that contributes to the pollution in the world. And the main speaker before the film will be Andy Lipkis. Andy Lipkis is head of the Tree People. For those of you who don't know the Tree People, just drive up to Coldwater Canyon and Mulholland, and you will see the amazing work that that man has done. He decided to become caring about trees when he was a camper up in the San Bernardino Mountains, and he saw the trees turning different colors and dying, and that motivated him to get involved with what's going on in our environment. April 30th, Congressman Henry Waxman will be here talking to us, and since the districts have been gerrymandered, even though some of you may not be in his district, he will talk to us about an update on Congress and all the wonderful progress that's being made here. Hopefully. And then May 9th, we are going to do a program on California schools in peril. And for me, this is like my baby, because I taught across the street at Fairfax High School for 17 years, aside from other things that I've done in education. And I think it's critical for us to understand what has happened to education in this state. And the speakers will be Steve Zimmer, who just was reelected to the Board of Education, John Rogers, who's the director of UCLA's Institute for Democracy, Education, and Access, and Nancy Ramirez, who's the Western Regional Counsel for the Mexican-American Legal Defense and Educational Fund. And then two other films, which are, if you haven't seen them, they will blow you away. One is the film called The Revisionaries. It is about education in Texas and how 15 people have changed the education in Texas. They have gone through the textbooks, they've scratched out what they don't like, and the Texas State Board of Education is now rewriting the text standard for nearly 5 million children. And our last film, which is in July, the film is called, my French accent, please excuse, La Rafle, and it is a documentary about the mass arrest of Jews on French soils, where 13,000 people were rounded up and deported to death camps in Poland. If you read the book Sarah's Key, this is the original film that Sarah's Key was taken from. So I don't want to take any more time. I just would like to introduce to you our wonderful, wonderful moderator. Dave Bryant has been with us for a long time. He is just one of our favorites. He is now on KCAL. How's the whole thing going now? KCAL Prime 9 News, is that right? And KCBS. Okay, we're putting it together. Now, why is this panel today so important? Because last night and this morning, I was reading the news and watching the news, and there was Paul Ryan. And Paul Ryan has produced a budget where health care is going to be provided to our citizens by vouchers. And so my question is, what will happen to me when my vouchers run out? Is that when I have to be put out on the ice? What will happen? And hopefully the people here on this panel will help us. So Dave is our moderator, and one of the things I think is absolutely fascinating about Dave, you have his bio, read it, because this man has done everything and been everywhere. But he is the only TV reporter who covers political stories only. So Dave, take it away.
Thanks very much. So we've got a lot to talk about today and not a lot of time to do it. So first I want to urge you to put your questions in, because at 1 o'clock that we're going to take questions, and I think a lot of the questions will be about how these changes in healthcare in America are going to affect you, and that's an important issue. What we're going to do here is I'm going to introduce our panelists, and they're going to each talk a little bit about themselves and their focus on the healthcare issue, and then we're going to have a discussion about what the Affordable Health Care Act is. Now the implementation of that act is actually a work in progress. It's actually begun, and in the next few years, people will start to see major changes in the way healthcare is delivered in America, who's covered and who isn't. Then we're going to talk about whether the Affordable Health Care Act is the first step in a larger change that may be coming, or is it an end in itself? And then finally, the most important part will be your questions and how it's going to affect you, or whatever questions you may have about it. So let me start with the introductions. First, California Insurance Commissioner Dave Jones, to my immediate right. He was elected in November 2010 with 4.7 million votes. He leads the California Department of Insurance, the largest consumer protection agency in the state, which regulates the $125 billion insurance industry to whatever extent it can, right? It can be regulated. That may be an issue we'll talk about today. Next to Commissioner Jones is Molly Favela. And Molly is the Education and Outreach Coordinator for Physicians for a National Health Program California. She oversees the Community Clinic Outreach Program, the Speakers and Writers Bureau, educational training, and the organization's electronic communications and social media. Next to Molly is Paul Song, Dr. Paul Song, a board-certified radiation oncologist and a board member of Physicians for a National Health Program California. He relocated to Los Angeles in 2007. Also, he is an executive board member of the Courage Campaign and co-chair of the Asian American Finance Committee for California Attorney General Kamala Harris. And he was a frequent contributor to Larry King Live during the healthcare reform debate. So I'm going to ask everyone on our panel to talk a little bit about themselves and about this issue, and then we'll get into the discussion. And Commissioner Jones, we'll start with you.
Thank you very much. It's a great treat to be with you here this afternoon, and I'm just going to plunge right in. I guess the title of my remarks will be, the world is changing, but it's not changing enough. It's not changing fast enough, in my view. The world is changing, but it's not changing enough. So let me begin by saying that I think that the ideal solution set that regrettably Congress did not enact was a single-payer universal health care system. That's not what we got out of Congress, but I wish we had. Had we gotten it, basically what they could have done was take Medicare, drop the age eligibility requirements, and make it available for everyone at a much lower administrative cost, higher efficiencies, greater savings across the system. We didn't get that. We should continue to fight for that. In 2017, California will legally have the chance to build on the Affordable Care to get to that, if we are so inclined. We have a lot of work to do, though, to educate Californians about the importance of single payer, why it would be a better solution. What did we get? The Affordable Care Act. Now let's break what we got into two categories. The immediate benefits that have gone into effect right away that I'm helping to implement as your insurance commissioner, and then what happens in 2014. Immediate benefits. One of the first regulations I issued on January 3rd, 2011, at my swearing in, was a regulation requiring health insurers to put 85 to 80 cents of every buck they collect from us in premium into actual health care. This is to implement an important part of the Affordable Care Act that requires health insurers to put more of our money into actual health care instead of profit and overhead and administrative expense. It wasn't too long ago that Anthem Blue Cross only put 60 cents of every buck they collected from us into actually paying doctors and nurses and hospitals and clinics. They kept the other 40 cents. Now under the Affordable Care Act, they've got to put in between 80 and 85 cents. That's a good thing. The other immediate benefits are if you're on Medicare and you fall into that dreaded donut hole when you got to dig into your pocket and start paying for prescription benefits, the donut hole gets closed. If you're a small business, you get a federal tax credit to defray the cost of providing health insurance to your employees. If you're a kid and you have a pre-existing condition, it used to be that health insurers denied children health insurance due to pre-existing conditions. Thanks to the Affordable Care Act, they can no longer do that. If you're my friend Paula Velasquez, you get to stay alive. Paula Velasquez is a young woman who was diagnosed with a very rare form of children's cancer a couple years ago. Thankfully, she had health insurance. Turns out her chemotherapy treatment cost $60,000 a treatment. And very soon, she ran up against what's called an annual limit and a lifetime limit in her health insurance. And that's not unique. Most health insurance policies used to have annual limits or lifetime limits. And that limit meant no more treatment for you. And she ran up against the limit, and but for the Affordable Care Act, striking those limits from health insurance policies, I don't think she'd be with us today. But she kept getting the care she needed, even though the price of that care exceeded that limit. They beat the cancer back into remission. She's a vibrant, active, dynamic young woman today, very, very much active in advocating around health care reform. So her story is not unique. I've met countless Californians who are alive today because of the Affordable Care Act. Certain co-insurance and co-payment requirements for preventative care are eliminated. Certain women's preventative health is now not co-payable. It's eliminated to encourage more women to get that kind of care. So the list of these immediate benefits goes on and on and on, and we can spend a lot more time talking about them. But now I want to shift to 2014, when an even bigger change happens. And in 2014, the biggest change of all is health insurers will no longer be able to deny adults health insurance based on pre-existing medical conditions. They will no longer be able to discriminate, and that's worthy of applause. It truly is. That's a good thing, and that's a big, big change under the Affordable Care Act. Second big change is that there'll be a new web-based insurance exchange, and we can talk a little bit more about this in detail, but essentially this is a place you go on the web and you can purchase health insurance. There'll be a lot more transparency because you'll actually have standard benefits required from each health insurer and HMO that will let you compare their products across health insurers in a way that can let you compare them based on price and on level of cost sharing. Every health insurer and HMO that's selling through this health benefits exchange called Covered California will have to offer these standard benefit products. They'll have to offer them at different levels of co-insurance, which means different levels of where you pay versus the insurer pays, 70, 80, 90, 100%, and you can do a comparison based on price. That's a big deal. What's missing from the Affordable Care Act? Well, no public option, very, very regrettable, but even worse, no authority in the Federal Affordable Care Act to give insurance regulators the ability to reject excessive health insurance and HMO rate hikes. It's nowhere in the bill. And sadly, and perhaps surprisingly for many of you, because I run into this all the time in California, your insurance commissioner under state law does not have the authority to reject excessive health insurance and HMO rate hikes. Now, I have that authority since 1988 under a law the voters passed called Proposition 103. And since 1988, insurance commissioners have been able to regulate auto insurance and homeowners insurance and all other casualty and property insurance. We've saved consumers and businesses tens of billions of dollars. The insurance companies are still making reasonable profits. They're writing insurance in all those product lines. But guess what? Not health insurance, not HMO. In fact, one of the first things I also did when I got into office was I looked at medical malpractice insurance rates, the insurance that doctors and nurses and other medical providers have to get, and I discovered that the health insurers were only paying out about 50 cents in every buck they collected from that. So I ordered them to reduce their rates. I've saved doctors and nurses and others $46 million a year in premiums for medical malpractice insurance. But I can't do that for you in the health insurance space because the law doesn't let me. Now, this is not a radical concept. 34 other states have given their insurance commissioner the authority to reject excessive health insurance and HMO rates. California has given its insurance commissioner that authority for car insurance, for homeowners insurance. Some of you who own homes may have noticed just the other month, I ordered State Farm to reduce their rates 12.6%, saving 1.6 million Californians, $150 million for homeowners insurance. But what can I do with health insurance? I can just call them out when I think the rate is excessive. And 2 weeks ago, I did that exactly with Blue Shield, raising their rates up to 19% on 260,000 individual customers. We looked very carefully at their rates. We determined that they were over-projecting their costs, their administrative costs are too high, too much overhead. And I talked to the CEO and said, look, this is too much. You shouldn't do this. And they said, sorry, Commissioner, we're doing it, and you can't stop me. And that's exactly what we did. We called them on it publicly, but they can go forward with it. And we're seeing these double-digit rate increases year after year after year. Now, what can we do about that? We can change the law. I've been fighting to change the law for 6 years now. I've had 4 separate bills that I've either authored as an assembly member or sponsored as insurance commissioner to change the law to give the insurance commissioner the authority to reject excessive rate hikes. Well, guess what happened? Each of those 4 bills, we got it through the first house, the assembly, and then it stalls out in the Senate. Why? Well, because of the power and influence of the health insurance and HMO lobby, they're able to get enough Democrats together to block that bill. Sadly, no Republican will vote for it. So after 6 years of trying the same thing, I think you need a plan B. And Paul's going to talk a little bit later about plan B, because I'm running out of time. But I do think we've got to change the law, and we'll have a chance to do exactly that. And I'm happy to take questions on anything I've talked about or anything else you'd like to talk about health care reform and health insurance. And I really appreciate you coming out today, because your interest and willingness to learn about this and then to be engaged with your family members and co-workers and neighbors on this issue is critically important, because here's why. There are those who are out there who are still trying to rip apart the Affordable Care Act. And it's not perfect. It needs to be improved. And I've explained some areas where we need to desperately improve it. But it's a foundation on which we can build to get the single payer. And if the foundation gets ripped out, you don't get to build the house. So we need you out there explaining the importance of this and the benefits of this to Californians so that we protect that foundation and we can move forward to what I think ultimately is where we should go, which is single payer, universal health care reform. Thanks for your attention. I'm sorry I'm talking so fast. But there'll be time for questions in a minute. Thanks a lot.
So we'll move down the line. Molly, why don't you go next?
Oh, okay.
Microphone.
So thank you very much for having me. I feel honored to be sitting on the panel with these 2 amazing people. And I just want to echo what Commissioner Jones said, that I think the ACA is going to do a lot of great things, but we still have work to do. And I also want to say I feel very lucky that we have Dave Jones as our insurance commissioner in California. And I hope that, he gets the power to regulate insurance companies to within an inch of their life, or better yet, just to remove them completely, right? If we remove them, then we can, that would be going toward a guaranteed universal healthcare system, also known as single payer, where you basically just put the whole entire healthcare system under one umbrella that's publicly accountable. When's the last time you called your CEO to let him know you weren't happy with your service? Probably never, right? So I think the first question is, can we go to single payer eventually? I say yes. The second question is how? And I want to talk a little bit about that. And I first want to address the fact that we don't have single-payer legislation this year for the first time in 10 years in California. And that's okay. Sacramento is sending us a message that they want to work on the Affordable Care Act. And that's okay, because 2013 is a big year because, as Commissioner Jones said, 2014 is where the magic happens, right? A lot of big changes are coming. And they should be focusing on the ACA. But I think that for single-payer supporters, and I know that National Council of Jewish Women LA does support it, we also need to be looking at the Affordable Care Act and where we can build on it or insert into it things that are going to get us closer to single-payer or to single-payer itself. PNHP California, the organization that I work for, is one of the organizations that we solely work towards single-payer, and we are doing this. We're researching the Affordable Care Act. Especially the exchange. We have a lot of hopes for the exchange. The board of the exchange is very progressive, and they themselves have said they want to be a catalyst for change in the California healthcare system. And we can talk about this more later. But we're doing this research because we have a plan. We have what we're calling the 5-year plan. As Commissioner Jones alluded to, 2017. In 2017, the Affordable Care Act will give us the state innovation waiver, and that allows us, California as a state, to implement its own healthcare system as long as it covers as many people, is as affordable, as comprehensive, and doesn't bust the federal budget. And so, we want to be ready for this, but we have our work cut out for us. So we do, as I said, have a plan. We need to get more funding for this movement because we need to do a massive marketing campaign. We need to do a lot of education out to our citizens and to people living in California. We need to work on our grassroots organizing and our advocacy, and we need to pass the bill. And after we pass it, we need to defend it. We need to turn it into a watchdog organization, defend it, and protect that bill that we've gotten. And I just want to let you guys know that we are doing this. We've started this process. We're bringing in a lot of experts, health policy experts, organizing experts, and people who can help us with this plan. And I also want to let you guys know that we're not doing it alone. There are a lot of organizations that are working on this. So PNHP California is obviously, we have a lot of healthcare providers and a lot of health policy people and public health people. But there's also a student organization, which I also represent, called the California Health Professional Student Alliance. There are 5,000 students strong in California, and they are very amazing. They have their own student board. They put on the only single-payer lobby day in California every year. If you're a student or know a student and you want to fight for healthcare justice, I suggest that you get in touch with me so you can learn more about them. But we also have Healthcare for All California, which is a grassroots organization. They have 20 chapters around California. They do a lot of education. We have California One Care, which is an organization that focuses on social media and also Netroots. And we also have Single Payer Now, which does a lot of one-on-one enrollment on the streets. So I just want to let you guys know that there are people working on this now, that we need to do it now to get ready, because California is a huge state. And people need to know what their options are around the Affordable Care Act. So I'll stop there and give other people a chance to talk.
Thank you again for allowing me to come and be part of this great panel. Over 20 years ago, C. Everett Koop, who just passed away, he was Surgeon General, and he actually administered the Hippocratic Oath to me when I was graduating from medical school. And one of the things that we did was we raised our hand and we said, I will follow that system of regimen, which according to my ability and judgment I consider for the benefit of my patients, and abstain from whatever is deleterious and mischievous. Fast forward, the last 20 years have been nothing but deleterious and mischievous in terms of the actions that you see. And that's why it's so important that we have someone like Commissioner Jones in office to really stick up and stand up for patients' rights. And he can't publicly say much about it, but he's up for re-election next year, and I hope everyone will go out of their way to really not only support him, but tell everyone about all the great work that he's doing. Along those lines, one other thing that again, he cannot mention is that Consumer Watchdog, and I was part of an organization, we helped collect enough signatures to qualify a ballot initiative since the California legislature was under the control of the insurance lobby, to basically pass a proposition to give the state insurance commissioner the right to regulate rates. So that'll be up in the next election, and I really hope you all will turn out in record numbers to finally give Commissioner Jones the right to really put some muscle behind his office to really crack down on these insurance companies that are really charging exorbitant rates. That said, I just want to give you a few facts that I think are very important. While we talk about the Affordable Care Act, I was one of the people that was very much supportive of President Obama's attempt, but really thought that what we ended up with was very, very disappointing. But rather than sit there and lambast it and continue to just sulk, I think it's important to embrace it and try to make it better. But having said that, I really do think it's disingenuous when you see Democratic legislators get out there and say that this is universal health care. It is not universal health care. 23 million people will still remain uninsured. And in the state of California, it's estimated that over 4 million people will remain uninsured. That's well too many people. And we know that strictly every year in the United States, roughly 40,000 people die every year strictly because they don't have insurance. So I'm really tired of Paul Ryan saying how he's so pro-life, but passing legislation that is so anti-life. So I think it's very important that life begins also when you're born. The other thing that's really important to realize is that last year there were 4 million bankruptcies in the United States, and 2/3 of these bankruptcies were due to medical illnesses. And what's staggering about that is, of those people that had medical-related bankruptcies, 3/4 of them had health insurance. So if you have health insurance, how is this supposed to happen in our country? Again, one of the things we need to do is to give Commissioner Jones the right to make sure these types of things don't happen. The other thing that's very important to realize is that the Affordable Care Act will have some major problems. We know from what's happened in Massachusetts and the implementation there that we can expect certain of those things to continue because they were never written really into the Affordable Care Act. One is that in the state of Massachusetts, the number of medical-related bankruptcies has continued to go through the roof due to, regardless of the number of insured, and that healthcare costs have continued to climb. So, as Commissioner Jones had mentioned, this medical loss ratio where he's making insurance companies spend 80 to 85% of every dollar they collect on actual patient care, if they continue to be able to raise rates, that's still going to cause a climb. So that's, again, tied into the ability to do that. The other thing that I want to mention is this Medicaid expansion, which is a very crucial part. It doesn't so much affect maybe many of us in this room directly, but in the whole big picture of healthcare in the state of California, it does. So part of the thing that you saw Jan Brewer in Arizona and Scott in Florida is they all of a sudden found religion and adopted the Medicaid expansion for their states. And Governor Brown has said he would do that here as well. And what that is doing is it's money that's 100% funded by the federal government, at least for the first 3 years, to expand Medicaid for those people that are making 133% and less of the poverty line, so that they can now have health insurance. And doing so, it's passed both the Senate and legislature here, Assembly, but there has been some discussion by Governor Brown and his staff to exchange that money. So that money would go to expand Medicaid, but then he is potentially going to take money from the local counties through realignment, and that's discretionary funds. And what's crucial about that is Medicaid covers the poor, but it doesn't cover the undocumented. And a lot of the money that would be taken away, sort of a shell game, I'll give you the Medicaid money and you give me back the county money, is currently being used to cover the undocumented. And if we continue to keep more people uninsured, ultimately that's going to drive up everyone's healthcare costs. Because, like it or not, the way hospitals justify jacking up and charging exorbitant rates is because they say they're offsetting the cost of treating the uninsured. So as long as we continue to have this 4 million uninsured, that is a problem that we'll have. So as Molly mentioned, we're all big single-payer advocates, but realizing the political reality, we have to go incrementally. Rather than blast the Affordable Care Act, we reluctantly adopt it, embrace it, and try to support it and build upon it. But the crucial parts are to make sure that we give people like Commissioner Jones the right to make sure that it's fully implemented to its maximum potential. Thank you.
I want to ask you, first of all, these recent rate increases from Anthem, Blue Cross, and other insurance companies, are they in anticipation of the implementation? Or is there a connection between those rate increase requests and the Affordable Care Act going into place?
Oh, only marginally. I think what we're seeing is just business as usual, and that is the unfettered ability of health insurers and HMOs to charge whatever they want and make whatever they want. And the pricing behavior of for-profit and non-profit health insurers and HMOs really is indistinguishable. In fact, Blue Shield is a non-profit corporation, but its pricing behavior really isn't significantly different from Anthem, Blue Cross, or anybody else. In fact, it's less administratively efficient than some of these others too. So we've endured double-digit rate increases each year over the last 10 years in the individual market, where individuals and families go to buy health insurance, in the small business market, and in the large business market. And that's particularly telling because it's the large employers who actually have the most bargaining power. And perhaps the largest large group or large employer of all, if you will, is CalPERS, right? It's negotiating on behalf of literally hundreds of thousands of people. And yet it is still facing double-digit rate increases. Why? Because this is an essential good that people desperately need. They're willing to pay just about everything to get it until the point where they can pay no more, and then they become uninsured. And the health insurers and the HMOs know that. And they're making enormous profits as a result. They're making returns 20, 25, sometimes as high as 30% return on equity. at a time when we're still clawing our way out of the worst recession since the Great Depression. So I don't see it driven so much by the Affordable Care Act as I see it just driven by business as usual, and it will continue after 2014, and in some ways may accelerate after 2014 because of some of the requirements of the Affordable Care Act. So again, the missing piece of the Affordable Care Act, in my view, is the absence of the authority of any regulator to say, enough's enough, you're charging too much, you're making too much, your overhead and administrative costs are too high, you're misprojecting your claims experience. That doesn't exist in the federal law, that doesn't exist in state law, we need to change that.
Well, in theory at least, and I'm putting this down for anybody on the panel, where is the affordable in the Affordable Care Act? They must have, at least in theory, there must be some way they expect to keep it affordable.
So let me,
I'm not hearing that.
No, well, true. Let me take a stab at that, and then I'll defer to the panelists who gave excellent presentations. So it is true that, as Paul said, one of the big positive things of the Affordable Care Act is the ability of states to expand their Medicaid programs, or what we call in California Medi-Cal. And right now, Medi-Cal eligibility is limited to those who are essentially aged, blind, disabled, or who have kids. Under the Affordable Care Act, single individuals who are poor but don't meet those requirements, and poor up to about 138% of the federal poverty level, will now be eligible for Medi-Cal. That's a big deal. That's about 1.5 million to maybe as many as 2 million uninsured Californians who get care, as Paul mentioned. They get care, they just get it in the emergency department where it's really expensive to treat them, and they're really sick because they got no care prior to then. And then guess what? The hospitals don't just eat that cost. They shift it, if they're a public hospital, to us as taxpayers, or they shift it, if they're a nonprofit or private hospital, to us as health insured ratepayers. It's estimated that the premium that each of us pays as a family for health insurance, those of us that have it, is increased by $1,400 as a result of this cost shifting that goes on, because the uninsured are getting care, they're just not getting insurance to cover their care, so the medical provider shifts the cost to the rest of us. So yes, affordable in the sense that poor people up to 138% of poverty level will now have a chance if the state elects to expand in this way, and it looks like California will. I agree with Paul's analysis that we shouldn't do it in a way that robs the counties of their ability to help the undocumented, because guess what? The undocumented don't get anything out of the Affordable Care Act. They can't buy through the new health benefits exchange. They're not eligible except for very narrow circumstances for Medi-Cal. So, but the Medicaid expansion, assuming we don't take money from the counties unduly, is a good thing. Then the other piece that will help, although I think ultimately it will be overrun by the rate increases, is a subsidy. So those between 138% of the federal poverty level, which in California for a family of four is maybe around $30,000, to about 400% of the federal poverty level, which in California for a family of four is about $84,000. Those between about $30,000 and as high as $80,000 for a family of four will get a subsidy in the form of a tax credit that comes right off the top of the premium if they buy their health insurance through this health benefits exchange, this internet-based marketplace that I described a moment ago. It's a sliding scale subsidy. Here's what I'm worried about, though. I'm worried that the subsidy isn't big enough to keep up with the rate increases. So, you know, when people talk about affordability, it's the Medicaid expansion, it's this subsidy, it's a tax credit for small businesses. But if, as I think is going to happen, rates keep going up, then that subsidy gets washed out by the rate increase. And that's a problem, and it's a problem I think we can fix, and we know how to fix. 34 other states have fixed it. We fixed it for auto insurance and homeowners insurance, and we ought to fix it here.
I just want to say that, so just in California, between 2003 and 2010, premiums went up about 60%, where average wages only went up 4%. And more employees are being asked to pay more of the share of their healthcare costs. What Commissioner Jones mentioned about this voucher, it's very interesting. To buy private insurance is what Paul Ryan is prescribing for Medicare, is to turn it into a voucher system. And if you look at what the average rate of increase in the premiums has been versus what the amount of subsidy support would be for Medicare, that's where that gap would get big. And so what Commissioner Jones says is very true, that unless rates are regulated to keep them low, that delta between the rates and what the government pays you is going to increase, just like the argument against doing a Medicare support voucher system.
Well, is the theory that the federal government or these exchanges would negotiate lower rates because they would represent a huge marketplace for the companies? I mean, is that the basic idea?
That's the theory, but here's what was interesting. So Comptroller John Chung was telling me that CalPERS was trying to negotiate rates. And they're bigger than most exchanges when you look at the sheer number of people. And yet they can't get good rates from Kaiser and the like. So I think the idea that pooling these people together is great in terms of the economy of scale, but ultimately they still will not have the bargaining power that they're meant to have.
And the other data point I would add to what Paul said, yes, the theory behind the health benefits exchange, or what we're in California calling Covered California, is that this entity will go out and negotiate on behalf of a couple million individuals and small businesses that are out there alone trying to negotiate for health insurance. Well, good luck, right? When you're an individual, you're not negotiating, you just take the price. And every year they tell you, hey, we're skinnying down the benefit, we're raising your deductible, we're going to increase your copayment. It's not a negotiation, it's take it or leave it. And at some point, you hang on desperately, and then the price gets too high, and then you fall off, and you can't afford it anymore, and that's why we've got about 7 million people without health insurance. So the idea is Covered California will go and negotiate, hopefully, a better price. But here's what happened in Massachusetts, and Paul alluded to this a moment ago. Massachusetts adopted the Affordable Care Act in 2005, despite Mitt Romney's protestations to the contrary. Right? It's fact. It's fact. It actually happened. And it had the same elements of the Affordable Care Act. It had a requirement that everyone get health insurance. It barred the health insurance from discriminating against people for pre-existing condition, and there was a health benefits exchange. The idea was the health benefits exchange would go out, negotiate better prices, bring the price curve down, and they were subsidizing that health benefits exchange for middle and lower income working people out of the general fund of the Commonwealth of Massachusetts, not a federal tax credit, but same idea. There was some subsidy between, 200%, 3% of the federal poverty level in Massachusetts. And so, what happened? As Paul said, prices kept going up even in their health benefits exchange. And the prices outran the subsidy. So they're shoveling money out of the general fund of the Commonwealth of Massachusetts to keep up with this thing. And finally, 4 years later, the new governor of the Commonwealth of Massachusetts, a fine gentleman named Paul Patrick, who's a friend of mine, said, whoa, this isn't working. And guess what he did? He found a dusty old Massachusetts statute that gave his insurance commissioner the authority to reject excessive rate hikes and declare, hey, we're going to start doing this. This is the big missing piece of this whole thing. And so, to me, that's the best evidence that, despite the best theory about how these exchanges work, I think the rates are going to continue to go up, and we got to fill that missing piece.
And I just wanted to add that you can go online and see for yourself, coveredca.com. The exchange website is up. They have a lot of information on there, including what it actually would cost you. They have a cost calculator, and we have to remember. And I'm just going back to the question is this affordable? And that is the question, because maximum out-of-pocket cost for a family is over $12,000. For an individual, it's $6,000, and that's on top of your premiums. And then also when you look at those, the metallics, as they're calling them, the bronze, silver, gold, and platinum plans, the bronze plan is only covering 60% of your costs. So you're on the hook for 40%. As he mentioned, I work with community clinics, and I talk to them, and there are patients who are eligible for the exchange because you don't need to go to the exchange if you get insurance through your work. But many of the patients who go to clinics don't get insurance through their work. They're already saying they're not going to do it. They're not going to buy insurance. They're just going to pay the fine that comes with the individual mandate because they can't afford it.
So for those who already have, are either part of the Medicare system or have coverage through work, through their employment, will there be any changes for them? I mean, in terms of coverage, will additional types of procedures be covered, or how will that work?
So for those of you who are on Medicare, there are some good changes. One is there are certain preventive services that you're now entitled to get through Medicare as a result of the Affordable Care Act. Annual exams, other preventative services that you don't have to pay co-payments for. So that's a good thing. And that's designed to try to encourage Medicare beneficiaries to go in and take advantage of these preventive services. The other good thing for Medicare beneficiaries under the Affordable Care Act is the gradual elimination of the donut hole, which is that point where if you're taking very expensive prescription medications, the Medicare prescription drug benefit only covers to a certain point. Then you fall into what's called the donut hole, where you got to pay for it yourself. And for some people, that's thousands of dollars until you get out on the other end after you pay thousands of dollars, and then it picks up again. Well, the Affordable Care Act is gradually eliminating that. The first year, there was a rebate. Second year, you get to have access to cheaper drugs, and over time, the donut hole goes away. So there are some benefits to Medicare recipients. By and large, though, the Medicare program, other than the benefits, is not going to be diminished in any way. Then, for those of you that have insurance through your employer, okay, so here's where it gets interesting. So, if you're insured through your employer, and remember, employers who have 50 or more employees have to either provide you health insurance or they're going to pay a penalty for not doing so. So, if you have insurance through your employer is going to do a calculation, many of them. And the calculation they're going to do is whether it makes more sense for them to pay the penalty or to continue paying for your health insurance. Now remember, they're also facing increased costs too. Maybe at a slightly lesser rate, but nonetheless increasing costs also are occurring in the large group market. Even as a number of us have mentioned, CalPERS, the largest of the large group purchasers, the one with the best bargaining position, is facing double-digit rate increases. And they're in the best position of all. So large employers are also facing these rate increases. So they're going to do this calculation, and they're going to decide whether to continue to provide you with the health insurance or to decide, look, you're on your own. We'll pay the fee. It's cheaper for us to pay the fee. Now, there's some mixed data out there. There have been some surveys, and some surveys say they're all going to stick with it. Some surveys say some number of them are going to fall off. I'm not sure we know. We hope that many of them will stick with it. And we hope that there are benefits other than just the pure economic calculation. They have a little more control. They can be more assured of the kind of things they want you to get as your employee. So our hope is that they all don't just run for the exits. But some number of them might, in which case then their employees will be shopping through this health benefits exchange. And that may present challenges based on what your income is, and based on how high the rates go up, and based on your eligibility for a subsidy.
And sadly, what you're seeing is, during the whole healthcare debate, they said, well, if you like the insurance you have, you get to keep it. Well, I don't think many of us like the insurance that we have, but we're staying in our jobs because we get health benefits, and I think that that's something to realize. Companies like Olive Garden and Domino's, Domino's have really started to roll back hours for their employees. So if you work less than 40 hours, they're not responsible to give you health care. So there are a lot of ways that these companies are starting to shirk the responsibilities. One of the things that Commissioner Jones had mentioned was the idea that it's really hard to tell who's for-profit and who's not-for-profit. I think it's safe to say that even the not-for-profits are for-profit. They just find a way to hide their money a little bit better. The only true not-for-profit in the healthcare system is Medicare, which does things much more efficiently. Its administrative costs are estimated to be 2 to 3%. And every cent is basically used to take care of actual patient care and not to reward shareholders or exorbitant CEO salaries. And that is ultimately where we hope the Affordable Care Act will be the foundation and eventually allow us to get to a Medicare for all in some capacity.
So, when Medicare was first established, critics called it socialized medicine.
Right.
Now critics call single-payer system socialized medicine.
Right.
So what's the difference? I mean, just for those of us who
So,
don't really
yeah.
understand, what's the difference between single-payer and what we have now?
This is something that's, well, first and foremost, socialized medicine was actually a term that was coined by the American Medical Association back when the Medicare debate was started. And what they did was they hired an aspiring, strappy young actor by the name of Ronald Reagan to record a record, and they gave it to the wives of physicians to play at homes, coffees, so they could play it for all their friends. And in it, Reagan basically said that we will rue the day when Medicare is passed, and we'll look back as this was the start of socialism in our country. Not socialized medicine, socialism in our country. First and foremost, socialized medicine is where the government controls everything. They own the hospitals, they pay the doctors, every single aspect, the janitors, the nurses, the lab technicians, they run the pharmacy, they own everything. We have a socialized medicine system here in the United States. It's called the VA. And it's really ironic that our soldiers are fighting for socialized benefits. But that's really, we do have a socialized system, and actually it's run pretty efficiently. The patient satisfaction in the socialized program, there was a RAND survey that showed that patients were more satisfied, by and large, in the socialized VA system than they were in the general healthcare system. What we're talking about single payer is just where instead we're replacing the insurance industry that is truly for profit. Right now, they take 31 cents of every dollar away from actual patient care. That's money that could be used for patient care, but they use it for administrative costs, marketing. How many, Thrive ads have you seen, or Aetna Blue Cross ads have you seen? Well, that costs money, and that's money that takes away from actual patient care. And what a single payer system would be is you have one administrator. Right now, we've got 1,200 or so different plans nationwide. So if you're a doctor's office and you're dealing with patients, you're constantly on the phone trying to get authorization, approval. For many of you who are going to see a doctor, before you even get a chance to see a doctor, you've got to spend hours on the phone trying to get approval to do that. What a single payer system would do is remove all that administrative bureaucracy, and that money that would be saved from that would go back in to cover every single person in the United States. We have a country that does that. Canada does that. Now, comparing Canada to the United States is not fair. The United States has a population of 300+ million. Canada has a population of 33 million or so. But if you compare Canada to the state of California has 36 million, Canada has 33 million. And if you compared how a healthcare system is, Canada's economy is the 10th largest economy. California, depending on the year, is either the 6th or the 8th largest economy. We could absolutely implement what they're doing. And if you look at the way costs have gone in Canada over the last 35 years since the implementation of their single-payer system versus California or the United States, it's staggering. Their healthcare costs are half of what ours have been, and yet they insure everyone, and the satisfaction is quite high. Again, this is something just to think of because we're not going to be there in this political climate for a long time, but we should really start the discussion and the education on that.
But the critics say you would be replacing the for-profit bureaucracy with a government bureaucracy. Right. So they contend that it's a push.
Right. So this is where I think real facts matter on that, and that's where several studies have recently come out showing that Medicare is much more efficient than the private insurance industry, and that's what I meant. There was a recent study that just came out 3 months ago that showed the administrative costs for Medicare were estimated to be about 2%. And so if you look at that, and everyone says we have a free market in healthcare, we don't. The only two industries that are exempt from antitrust legislation in the United States are the health insurance industry and Major League Baseball. And so what's important is that the only way you can offset the competitive disadvantage, because most cities are controlled by one or two big insurers, there's been such consolidation, is to have some big single-payer system that can really negotiate rates. And even Medicare, because of Congress's cozy relationship with Big Pharma, is not allowed to negotiate pharmaceutical drug prices.
Well, Mama, you had mentioned 2017, and you were saying that at that point the states will have more leeway to make decisions about their own health care, the system that serves their state in some respects. Are you suggesting that California could go it alone on single payer?
I think that's probably the most likely way that we will get single payer. There is a national bill that would enact single payer, HR 676 by John Conyers, and it's been around for a while. But since we did just do the ACA, we don't know if that's going to do much for now. But in the states, we hope that we can use that state innovation waiver in 2017 to do our own thing. California's been a leader in health reform, and I think we should continue to be that. And also, when we look at the Canadian experience, when they went to single payer years ago, they started province by province. So they didn't do it all at once either. And actually, their single payer systems are administered by the specific provinces.
Commissioner, is that viable? I mean, could the state of California create its own single-payer healthcare system? I mean, it sounds like a huge change.
I think we could. I think we've got the know-how, the technical capability,
the money,
and you would save money. I mean, in the near term, there are some startup expenses, but I think almost every study indicates over time, and Paul's absolutely correct, and Medicare is the best example, that you squeeze out a lot of administrative inefficiencies through a single payer system. You get the middle person out of it, you get the profit motive out of it, and you have a system where it's really about trying to make sure that providers are reimbursed when people get care, as opposed to a system now where the middle person is looking to try to make as much as they can. And so I think we could do it. I think we should do it. I think we've got a big job on our hands, though, implementing this foundation, which is what I and others are working on this next year. And then we've got a big job also collectively in educating more Californians about the benefits of single payer, because there's been a lot of mischief caused by those who cast around aspersions or throw around false facts or try to paint this as some, radical thing. And so each of us, I think, has a responsibility to try to do more education, and we'll have the chance to do that. But if we don't build the foundation first and foremost, I don't think we get to where we need to go. And so many of us are focused on trying to get that foundation, but also improve the foundation. There's some big missing cornerstones of the foundation that I've mentioned that we need to fix as well, and I hope we do.
Well, Paul, single payer was briefly part of the discussion when the Affordable Care Act sort of was generated out of that debate, but it was pretty quickly cast aside as something that just couldn't be done.
Right, well, and part of the reason is if you look at, and I don't want to bash the process too much, but I think it's just the truth. If you look at the whole process, there were 3,300 registered healthcare lobbies for the 535 members of Congress. They were spending $1.2 million a day. Collectively, they spent more than what was spent on the Bush-Kerry election. And that's why this bill looks like it was written by the private insurance industry. And even before that happened, President Obama and then, at that time, Tom Daschle had met with Billy Townsend from Big Pharma. And they put billions of dollars in up front to help promote the Affordable Care Act in exchange for them not touching big pharmaceutical, not slicing any benefits there. So that's why this bill looks like it was written by the private insurance industry. So what we need to do is try to take it and try to protect consumers as best as possible, but recognizing that as long as you keep this for-profit industry as the gatekeeper for this whole exchange, then we're going to run into problems. Their interests are not aligned with the interests of the average patient.
So do you see the Affordable Care Act as a framework for a possible single payer, or would the Affordable Care Act structure have to be scrapped and start over again?
No, I think and this is where I think what Commissioner Jones and the great work that he and his team have done is so crucial, that exchange and the whole online presence in all aspects of it, that framework is going to be necessary regardless. It's just a matter of if you replace all the several private insurers with a single insurer, which is the single payer, you'll still need that exchange for people to go on and sign up for health care and other benefits and things of that nature. So I think that we can use a lot of the good parts of the exchange for our benefit. And what's crucial is this: we don't need to necessarily put more money into the system. So Pennsylvania last week, there was Dr. Friedman from UMass was commissioned by the state. Single payer would save Pennsylvania $17 billion a year on healthcare costs. So if we look at that state being a fraction of our size, look at the billions we would save. So, and I'd let Commissioner Jones speak to that more, but I think what he's building is so crucial to the full implementation later on of a real perfect healthcare system.
I agree. The other thing I want to add is, I'm not doing this alone. There is a board for Covered California. The Brown administration is fully engaged, and the Obama administration too. We're all working together collectively on this. Each of us have different pieces, but I do think it's not for naught. In other words, I think that there are real benefits to implementing this in and of itself, and then it is something we can build on once we make sure we build the popular support for it to get the single payer.
Okay, we're going to start now with questions from the audience, and we have a lot of questions, okay? I'm a little overwhelmed here, because I'm trying to listen to what everyone's saying, and I'm reading through this stuff. Oh, yeah, okay. So I'm going to start, and we'll get through as many as we can. A lot of questions. So will the day come when insurance companies realize teeth and eyes are part of the body and should also be covered? Why aren't they? Good start, huh?
Well, I just want to point out that under a single payer system, dental and vision and mental health care and long-term care would be covered because of those savings that we would capture from eliminating all the administrative waste in California. So that's something to look forward to in the future.
But why aren't they covered now? I mean, the question raises a good point.
Well, the reason things aren't covered now is that health insurers and HMOs are free to decide what things they cover. Although there is a existing floor in the insurance code and in the Knox-Keene Act, which is the act that governs managed care plans. So that California under current law, sort of pre-full implementation of the Affordable Care Act, has some of the most robust set of mandates. But currently those mandates don't necessarily extend to adult vision and adult dental. In the Affordable Care Act itself, states were given the option to define what that essential health benefits floor would be that every health insurer and HMO has to meet after 2014, both for product they're selling through the health benefits exchange and for product they're selling outside. And each state was given 10 existing plans in their marketplace to choose from, and the legislature chose one that has children's dental, but not adult dental, and I don't think it had adult vision either. So now, health insurers and HMOs are free still to provide those things they see fit, and there was a big debate the other month about whether standalone vision plans could sell in the exchange. Initially, the exchange board said no. I didn't think that made a lot of sense. At least let's give consumers the ability to have access to that through the exchange, so we were able to get that decision overturned. But, you know, fundamentally, it was a political compromise that was made at the federal level about what sort of benefits at a minimum would be provided. Now, let me just share with you one other little anecdote from the front, if you will, with regard to benefits and coverage. That is one that is much on my mind. So I've been fighting health insurers principally over the last 2 years with regard to making sure they provide treatment for autistic kids. Because as you know, we have a growing incidence of autism in the United States and in California. A lot of debate about why, but no one disputes growing incidence. And so what happened was health insurers were denying the medically indicated treatment, which is called behavioral therapy, and saying it's education, not medical treatment. So I overturned those denials, and then I issued a bullet to them telling them to knock it off, and then I sued 5 of them and got a settlement agreement. And that all was great. And then that paved the way for Darrell Steinberg to pass a bill that clarified the law in this regard to say, hey, knock it off. You got to continue to provide behavioral therapy. But then, it's like whack-a-mole. They opened another front. So now, they're no longer summarily denying behavioral therapy for autistic kids, which again is the medically indicated, medical literature is very clear on this, the medically indicated treatment, the best treatment that has the best hope of helping autistic kids function and improve their functioning over the course of their life is behavioral therapy. No debate about that. So now what do the health insurers do? Well, now that they got to do it, we're making them do it, they come up with visit limits. All right? Oh, you're only going to get so many visits. Or cost limits. Or they say, look, you got to find a fully licensed physician to provide this, even though behavioral therapy can be provided by those that are not licensed. So I just issued an emergency regulation that the Office of Administrative Law just approved yesterday saying, knock it off. You know, if you don't have visit limits on the physical medical side, you can't arbitrarily impose visit limits on autistic kids on the mental health side. And the Office of Administrative Law approved that regulation. But it is a challenge because every time you think you've kind of got them in a corner, they pop out over here. And so that'll get a little bit better after 2014 because, again, we'll have this floor. But regrettably, there will be some things that won't be included. And so we need to continue to try to move, I think, to a better system, which is single payer, that covers all these things and gets all this administrative inefficiency and profit-taking waste out of the system.
In the meantime, one member of the audience says, why doesn't the Affordable Care Act allow consumers to purchase insurance across state lines? Wouldn't this increase competition and lower prices?
So that's a great question, and I oftentimes hear that as your insurance regulator. But as it turns out, Even were we to do that, we wouldn't suddenly have this influx of new health insurers or HMOs that aren't already here. Every national health insurer and HMO that is credible and can actually do a credible job is in the California market, okay? It's not like somebody's not here who would be here. The other thing is, you know, these are markets that are what are described by classical economists as naturally monopolistic or naturally oligopolistic markets. Why? It's an essential good. So the provider of the good can charge just about anything they want because you desperately need it. It's like water or electricity or natural gas and heating for your home, right? Well, in those markets, it's an essential good, and what do? We have public utility commissions that regulate the rates. Why? Because we're worried that it's an essential good and you'll be taken advantage of without that regulation. Or we have a municipal provider, right? Kind of like single payer would be if we had that. A municipal provider of that water or electricity or heating for your home. Why? Again, because it's a monopolistic market, and if you just allow it to be handled privately, the price is going to be too high. Now, the other characteristic of this market is you got to be really big. I mean, the 50 of us can't just go out and form a health insurance company tomorrow and we'll expect to be successful. So there are these natural barriers to entry as well. So, you know, the notion of let's just get rid of state-by-state regulation of health insurance, you're not really going to garner any benefits. But what are the disadvantages? Well, we actually have some of the most robust, admittedly, they don't go far enough in my view, but the most robust consumer protections in California compared to any other state. And that's not just for health insurance, it's for auto insurance, homeowner insurance, any insurance product line. These same kind of arguments are made. Why state-by-state regulation? If you got rid of state-by-state regulation, believe me, you'd have a race to the bottom. We would end up with if you had a national system of health insurance regulation or a national system of auto insurance or a national system of homeowners insurance regulation, all of the California-specific consumer protections would go out the window, and we would have the regulatory protections of very nice places, don't get me wrong, very nice places, like Mississippi, Alabama, you know, great places, right? But not a lot of protections for consumers. So I've looked at this question very closely because it's a legitimate question, but I am convinced that you don't get any benefit from eliminating state-by-state regulation, but you get a lot of disadvantages for Californians and California businesses. So I'm a big believer in let's protect our own, let's keep in place what we have, but let's build on it to make it even better.
Another question. Would you favor, and these are questions for anybody on the panel to address, would you favor regulating payment cost structure of all medical providers, doctors, nurse practitioners, nurses, administrators, social workers, so on and so forth? Can we require all concerned to post their prices?
So two separate questions. Number one, there is not a lot of transparency in pricing right now amongst medical providers. And I think anything we can do to have more transparency would be a good thing, because the more information that we as consumers have, the better choices we can make. And so there have been some legislative efforts to do this. There was a bill the other year that broke the gag clauses that exist between health insurers and hospitals that prevented either of them from revealing what the reimbursement levels are. That's helpful, although that information is now being conveyed in a way that's so aggregated that it's really hard for consumers to make sense of it. So I think we could do more on the transparency front. I'm not advocating for medical provider cost control, all right? I think we've got a big enough task convincing decision makers to go for health insurance rate regulation, okay? So what I'm proposing, and what I proposed in these 4 bills that I described a moment ago, and also what's being proposed vis-a-vis this initiative, I'll just observe this, is going after the profits and overhead and administrative inefficiencies of the health insurers. What that does, and what the other 34 states that have done this do, and what we do for the auto insurance and homeowners insurance, is we take the underlying medical cost structure as a given, and then we go from there, okay? And I think that alone is a big, big, big deal and a big positive change for California. And so that exactly is how that's structured, and I think we get a lot of benefits from doing that.
So I'm very much at odds with a lot of the CMA on this, but I actually think that it's less about what doctors charge, because really we are constantly regulated by either the insurance industry or Medicare in terms of what will be reimbursed. But I do think that we need to get physicians away from this fee-for-service, where they get paid each time they do a procedure rather than actually taking care of the patient, because the incentives are not necessarily the best aligned on that, and I think that needs to change. There was a paper that came out. These grad students from a university in St. Louis had gone through and called 2 hospitals in every state in the United States, asking them what they charge for hip replacement. And most of the time, the costs were all over the board. It was staggering. It was actually published last week in a journal. And it just shows you that the lack of consistency, both in terms of consumers, but also in terms of what insurance industry will pay. And that's where the variability lies, and that's where some of this administrative problems lie, and why it's so expensive for both hospitals and doctors' offices and the like to keep things going.
So I'm not quite sure I understand. How would you replace the fee for a particular service? You said for overall health care, but in some cases you need a specialist.
Right, so one of the things the Affordable Care Act is doing is setting up these accountable care organizations. The idea is that you work together as a team, so you don't duplicate tests, you don't order unnecessary tests, where you get a certain fee, lump sum, to treat the disease rather than per procedure. And by doing that, then people are more cognizant of the problem and less designed to just order tests for the sake of ordering tests. And we do know that, I was just saying that I don't want it to sound like single payer is just the insurance industry. We need to police and do a better job with hospitals and physicians as well. We certainly share our share the blame in terms of driving up costs in some capacity. So one of the ways you do that is by bundling this payment. So if you have diabetes, we're going to pay you this amount to take care of diabetes. If you're going to order all these additional tests and do all these additional screenings, you don't get paid any more or less for that. Sometimes you can take care of that patient without ordering half of those tests, but you do that because you get reimbursed for that.
Other options for payment are also global budgeting, where you just look at what the budget might be for one entity, like a hospital, for the year, and you give them that whole entire budget, and they have to work with that. Also, capitation is another way that they can pay. That means per patient. They just say, you have 500 patients, we'll give you this amount per patient. And I forgot what else I was going to say.
but why that's so important is because they once found that Duke University has more administrators dealing with negotiating with insurance companies than it does hospital beds. And the average doctor's office would save about $70,000 a year if we had a single payer system where it was just one form. So sometimes, even though your reimbursement per patient may be less, if you don't have to have somebody in your office on the phone continually getting approvals or fighting denials or doing all those things, you will save money in the long run.
But if you did have that kind of a fee that you're talking about, a sort of overall healthcare fee, wouldn't one really expensive procedure blow the whole thing out of the water?
Well, this is where you would really have a balanced cost. And one of the things that, Paul Ryan will say that Medicare is broke and that the system doesn't work, and it's not. It's because of who's in Medicare. That it's usually people that are over 65 and over, and there's this rule that 5% of the population controls 50% of the cost. And the idea is that if we put everyone into Medicare, so I would love to buy into Medicare. I'd rather give my monthly premium to a situation where I knew they had my best interest at hand and it wasn't about profit. And so as long as I'm staying healthy, I'm offsetting the cost of somebody who is needing the care, and that's what a real pool is all about.
Well, you mentioned this, Commissioner, you mentioned this before, because it seems to me that message hasn't really gotten out, because those who are opposed to this say, do you want the government controlling what surgeries you can get, or what medications you can take?
Well, the response to that is, do you want the health insurer controlling, what medications you get, because that's what we got now, and look how well that's working.
Well,
so,
that message hasn't gotten out, though.
Right. Well, it gets out, but it gets clouded by a lot of obfuscation and deception and misleading arguments. I mean, unfortunately, the opponents have, framed this as socialism, which it's not, and then the debate ends there. But, if you really look at it, I mean, it's not that government would be controlling that under single payer, but who's controlling it now, and how well is that working? So, I think at the end of the day, to me, the most compelling argument is just the efficiencies that are associated with moving in this direction. Taking the middle person out, taking the profit, taking the overhead out, And I'd be far more comfortable, even if under a Medicare for All system, where some set of, publicly accountable, right? Publicly accountable, because ultimately, you're right, at some point somebody's got to make some decisions about what gets covered or doesn't cover. Some set of publicly accounted people make that decision, as opposed to a health insurance CEO. I just think that's going to be a better system. I mean, we see that with Medicare. I mean, you don't have many of the same problems. Look, it's not perfect. I understand that. Some of you may have had some issues, but it's a lot better than what we have for everybody else in the private health insurance world.
The other complaint that you hear about that, though, is that people have to wait a long time, on a waiting list to get certain kinds of procedures done. And that in some cases, the care is more mediocre than it is in this country.
So as a cancer doc, I just want to speak from that perspective. When my own father had cancer, he could go get a test right away because he had Medicare. He didn't have to wait for pre-approval, pre-authorization to get a PET scan or get CAT scans or go for surgery. Whereas sometimes I see patients who are in these Medicare HMOs, and they have to wait a week or so to get authorization to come and see me. So the idea that, as a physician, Medicare never tells me what tests I can order, what drugs I can't prescribe, but I get that all the time from the private insurance industry. It's the biggest myth that's out there.
Molly?
I just remembered what I was going to say, and it's about regulations, and I think that those are important. And if we do look at Canada, every single provider knows exactly, how much, and every patient, how much you're going to be charged, and then they know what they're going to be reimbursed. And also, those things are renegotiated every year. Rates and benefits are renegotiated every year, so you get a say in what your care looks like over in Canada. And then another thing to think about is, when you have a single payer system, every single provider, every single hospital is on one system, right? So think about all that data. All of that data is going to go into one place. So you can really look and see, what doctors are prescribing, a certain medication. What's the norm? What's the average for that location and for that population? Are there outliers? Are there people prescribing too much or too little? And so it kind of helps you look at what's going on, and it helps you, address problems.
At the end of the day, we don't have infinite resources in any field of endeavor. And so, right now, we ration care. How do we ration care? Well, 7 million people don't get it until they're really sick and they show up in an emergency room, then it costs us all a lot more. So there's care rationing going on right now. Maybe the best argument might be that some people under a single payer system might have to wait a little bit longer, okay? But it's a value proposition, right? And I'm not even convinced that they're gonna have to wait that long. And then also, it's just simply not the case, just like Medicare, that those that have the wherewithal couldn't buy something on top of it, right? Because you can buy, right now under Medicare, right, a supplemental insurance policy that covers you more, covers additional things, whatever. That's not excluded necessarily from a single payer system. At least with a single payer it could be, but it doesn't have to be. In a single payer system, they'll at least cover the basics of everything, and if folks want to buy something more, they have the freedom to do that. But how do we make those decisions now? Well, the way we make them is some people get the care and some people get nothing. And to me, that's a terrible thing. That's just not, and it's not sustainable ultimately from a cost standpoint either.
A couple of questions, more about the Affordable Care Act. If you are an employer with just a few employees and wish to provide health care for employees, will there be any assistance for the employers? The questioner says, I personally have 2 to 3 employees.
Yes, for employers who have 25 or fewer employees, where your per employee average payroll is $50,000 per employee, you're eligible for an up to 50% tax credit to defray the cost of providing health insurance for your employees. You're also eligible to purchase your health insurance or managed care product through Covered California, which is the exchange. There's going to be a subset of the exchange just for small employers called SHOP, S-H-O-P. And you'll be able to shop at SHOP and have access to the same kind of transparency that's available to individuals. That is to say that the health insurers and the HMOs offering these small business products will have to offer the products with a standard benefit design at different levels of co-insurance or co-payment that allows you to compare across health insurers on an apples-to-apples basis based on price. So all of that will be available to you. Unless you have 50 or more employees, you're not required essentially to provide the health insurance, or conversely, you're not penalized for not providing it. But so sort of the gap then is between those between 25 and 50 don't get the tax credit. Those up to 50 can shop and shop, however. So if you're between 25 and 50 employees, you don't get the tax credit, but you get to shop and shop and get whatever benefits there are there. And the state has the ability to increase the availability of the tax credit up to those, I take that back. The state has the ability to allow up to employers up to 100 employees to shop and shop. It's chosen not to do so just yet. So that's kind of the architecture for small employers right now.
So for retirees who have turned over their Medicare to Kaiser, what changes will take place under Affordable Care?
Not so much nothing to them, but from what I understand, the government will reimburse Kaiser a little bit less for these Medicare Advantage plans. What happened was in the past, one of the things that was said falsely in the election was that the Medicare was being cut by Obamacare, and it's not. What they realized was that the amount of money the federal government was paying HMOs and private insurers to do these Medicare Advantage plans was much higher than what their actual costs were. And they found that in the end, those seniors were not really getting any better care. So what they've done is they've cut back on the reimbursement for Medicare Advantage. It should not affect seniors themselves in terms of what their coverages and benefits are. It just should hurt the bottom line a little bit for Kaiser and those that administer those plans.
We talked about the fact that a lot of people won't be covered, still won't have insurance under the Affordable Care Act. And the questioner asks, which groups will remain uninsured under the law besides undocumented immigrants? Are there other groups?
Immigrants who have been here, who are here legally but have been here for less than 5 years, are also not able to purchase or get on Medi-Cal and get some of the other benefits from the Affordable Care Act.
So it's undocumented, and then those that are documented that have been here less than 5 years. Those are the biggest groups.
We talked about, I think you mentioned, Commissioner, that you think there will be a ballot proposition giving the state insurance commissioner power to control the insurance rates.
I can observe this. I'm not allowed to advocate for the initiative because I'm here in my official capacity as your insurance commissioner, and there are very strict rules about this, but I can observe, and I will now observe, that there is a ballot measure that is qualified for the November 2014 ballot that would do precisely what you said, and then Paul can add more if he wishes.
So it's for small businesses and individual plans, so not everybody like CalPERS and the bigger plans, but and you're going to hear a lot of misinformation, a lot of money spent by the private insurance industry to say that this is detrimental to patients. As you've heard, there are over 33 states or 38 states in the United States already have passed this, that have given their insurance commissioners the right to regulate authorities. Most notably, New York passed this about 1.5 years ago, and there's been no drop-off in care whatsoever. This is absolutely crucial to ensure that we don't get overrun by healthcare costs more than we already have.
And we've talked a little bit about other ideas to control costs. Questioner asked, why are hospital costs so high and growing faster than the rate of inflation? What can be done to get these costs where they should be? One question I had along those lines, how much of it is a CYA attitude, that I don't want to be sued, so I'm going to order a whole bunch of tests that wouldn't maybe necessarily be recommended under the circumstance? I can't afford to take the chance.
I wish that was the case, but I think it's the biggest reason for ordering tests is you get reimbursed to order them, to order them, to do more procedures, and not to say that every doctor is driven by cost to do that, but inevitably that's a big part of it. I think the fear of being sued is such a small part of it, and I think it's overblown in so many ways. And I would say that single payer, just getting back to single payer, what they found was that when you had single payer, malpractice insurance went down dramatically, because why malpractice premiums are so high, or you're paying for the additional care of these patients in the long run. And when you have single payer and healthcare costs, it's covered by everybody. So let's say a doctor did do something detrimental to you, that your costs would be covered for the rest of your life through a single payer system. And as a result, healthcare malpractice costs would be less under a single payer system. I think it's the biggest fallacy that doctors order tests because they're afraid of being sued. I think most of the doctors that I've known in 20 plus years, nobody feels that way.
Is malpractice insurance a major healthcare cost, more so than maybe insurance?
Thanks to Commissioner Jones, not in the state of California.
It's certainly a lot less costly because, I mean, what I discovered was the medical malpractice insurers were charging physicians and other medical providers too much based on what they were paying out. And so, you know, one way to make sure that physicians and other medical providers are not having to pay out more than they should in medical malpractice insurance is by regulating the rates of medical malpractice insurance. So I did exactly that. One of the first things I did when I got into office was I ordered the 5 largest medical malpractice insurers to file their rates with me. And ironically, there I have the authority to actually regulate their rates because medical malpractice is technically what's called a casualty insurance. It's not health insurance. So ultimately, I was able to order between 20 and 30% rate reductions for medical malpractice insurance that will annually save physicians and other medical providers about $46 million a year in premiums they would otherwise pay. But I can't do that in the health insurance space. That's really frustrating. And it's particularly frustrating for consumers in California as they see their rates continue to decline 10, 20, 30, sometimes 40, 100%. And that's what we need to fix.
And it should be said that it's not just less, it's about 50% less. If you compare malpractice rates in Canada and California, they're about 50% less in Canada.
We're getting close to the end here, but I did want to read one card that I think illustrates the pressure that a lot of people are under. The questioner writes, I'm 85 years old, I have diabetes, asthma, serious arterial blockage. My prescriptions have climbed to $45, I think it's $45 instead of $1.20, whatever. I cannot afford medically to eliminate the pills, but it cuts into my grocery budget. Will Affordable Care Act, change that kind of a situation?
No, so one thing that I think gets lost is during the whole healthcare debate, you heard a lot of Republicans saying that this was the biggest government healthcare plan run in their lifetime. What people don't realize is Medicare Part D, which was initially introduced by Billy Townsend when he was a Republican representative from Louisiana, was a gift to the pharmaceutical industry. So much so that it was signed by the Republican House, Senate, and President Bush. And what it did was it gave seniors some degree of money to go buy drugs. But what it also allowed was the big pharma industry to jack up their prices a little bit. So let's say they normally charged $1, and now the government was going to give you 80 cents towards buying that. Well, pharma then made the drug $1.20. So the government was basically giving seniors a subsidy to go buy drugs from a company that was, an industry that was complicit in raising rates. And what did Republican Townsend do? As soon as he left, as soon as this bill got passed into law, he left to become head of Big Pharma. And it just shows you why pharmaceutical rates are immune to being regulated.
Yeah, Medicare cannot negotiate for drug prices. I mean, they should be able to because then they could get those bulk rates and save everyone money, but that was part of the deal. They can't negotiate for drug prices. And if you want to be shocked, so we've been villainizing the insurance companies, and we should be. In 2010, their profits were $12.9 billion. But if you look at pharmaceutical industry profits, their profits in 2010 were $39.2 billion. It's something, it's a huge, huge problem in America.
Well, I think did you have one more thing you wanted to say?
No, so sadly there's no relief in sight for the patient. That question, I feel bad.
Well, and sadly is the word, because I think a lot of the answers that we heard today were both enlightening, but in some cases very depressing as well. So, I apologize. Yeah, I mean, well, that's the reality, right? I'm not saying that, because of the way you gave the answer, but the impact of the information. Anyway, I want to thank our panelists. They were great. The National Council of Jewish Women LA for having this panel. Great.
so this was just really wonderful. I have so much knowledge that I probably will forget it when I walk out the front door, but I do know what we have to do next year for the 2014 election. Thank you for coming. Please fill out the yellow card. Please look at the programs that we're having, because the rest of them, I can't guarantee they're going to be as great as the people we have today. And today, Paul Song is a new father. So, congratulations, that is wonderful. And I have never met Dave Jones before. I heard him speak once in Sacramento. I'm so impressed. And for such a gorgeous young woman to be so knowledgeable, thank you. And of course, Dave is our old friend, and we can always count on him. So thank you so much for coming.